about the layers, the mucosa versus submucosa versus the externa, muscularis externa versus the serosa, or in the case of certain structures, adventitia. Yep. And we talked about how we distinguish each of these layers of the tube that starts in our mouth and ends up in our anus. And Juliet, I just wanted to confirm, rectum is columnar. We were talking about epithelium.
Yeah, columnar. Yeah,
just wanted to make sure. Yeah.
And yeah.
Because I was like, my
Yeah,
brain
and
was going back and
anus
forth.
is not very good.
Right. And then we came up to this discussion about the membranes. And this is pretty much where we stopped. And then in terms of the membranes, so this refers to everything as a mesentery, but there are distinct parts of the membranes, these mesentery. For instance, we have this really large, big hair net, as I like to think of it, called the greater omentum, which is a great place for storing adipose tissue. That's like its primary job, as well as sort of providing a little bit of structural support. If you're involved with surgery and you're in the surgery and there's an abdominal surgery happening, they're going to make an incision along the linea alba, which is the connective tissue that holds everything together, right down the midline. And that linea alba will be cut. And then the first thing that pooches out is little bits of the greater omentum, because it's right underneath the abdominal wall. Yeah?
When people get liposuction, do they suck out the greater omentum?
I don't think so. I think they go for these other places.
Yeah, like when they get like a tummy tuck, like also like a BBL, but like when they when they suck.
I haven't had one, so I can't.
Oh, you're right. Okay.
I don't need it.
So like, would it be more like? So it wouldn't be the greater omentum?
I don't think they would take the greater omentum because that's got a lot of connective tissue. I mean,
Yeah.
other areolar and right.
Okay.
So I think that they would go for patty, adipose tissue and mostly abdominal around here,
Yeah.
kind of stuff.
Okay.
But good question. So let me check it out. Where do they take? And again, it sort of depends on to what degree are they doing liposuction.
Yeah.
But here's the thing about liposuction. If you're ever thinking about doing it, it's great in the short term. But guess what happens if you don't change your eating habits?
Make more fat.
You make more fat. Why do you make more fat?
Because you have more calories coming in than you're expending.
And your body says, hey, we are short on adipocytes.
Oh, yeah,
We don't have a
lost so
place
many.
to store them. We've got to make more adipocytes because normally the adipocytes you have now, you keep. That's all you have. And you fill them up with triglycerides. That's how we get fatter. You fill up your adipocytes with triglycerides. When you take those adipocytes, by the way, adipocytes produce hormones that tell you you're full. And when you don't have the hormones to tell you you're full, you're going to eat more. Yeah, silly. Don't spend your money on that. Don't spend your money. There's so many other more important things to spend your money on. And liposuction is not one of them. Okay, so back to these. So we have the greater omentum that is attached to the greater curvature of the stomach, and we have a lesser omentum that's attached to the lesser curvature of the stomach. And this greater omentum, if you reflect it, if you flip it up this way, the other portion of it, because it's a double layer. So it starts here, it folds, and then it attaches to the transverse colon of the large intestine on the flip side. So that's one of the membranes. We also have tucked, all the loops of small intestine are suspended from the mesentery proper. This is what I think of as mesentery. I don't think of this as mesentery or that as mesentery. I think of them as greater omentum, lesser omentum, and I think of this as mesentery. And then our large intestine is suspended from a similar tissue called the mesocolon. Yes?
I was gonna ask about that. Is the mesocolon just deeper or?
The mesocolon is attached to the large intestine. Colon is your key there. Mesocolon for the large intestine. Both of them serve as a route for oxygenated blood to go to the enterocytes and for deoxygenated blood to come from the intestine, from the enterocytes, and from the lacteals, or the lamina propria between the villi. Yeah.
So like are those two mesenteries like classifications of the greater omentum and lesser omentum, or how are they different?
Yeah, so that's a sort of a more generalized term.
Yeah.
The greater omentum is that structure.
Okay.
and
Like the
for these
yeah.
purposes, they're referring to all of them as mesenteries.
Yeah.
So we're gonna distinguish.
So like for example, with the greater omentum be classified as an anterior mesentery because it's in the temple?
I guess. I like to say keep them out,
It can
just
smell your cereal.
keep them as separate.
It's like cinnamon, right?
Separate.
They are separate structures.
Okay.
Greater omentum, lesser
It's kind of
omentum,
like cereal, right?
mesocolon,
That's cereal.
mesentery. They have their distinct
Plus,
jobs.
since
Yeah.
I didn't-
Collectively all
I didn't
considered
I didn't
mesenteries.
I was
Nothing
like,
more.
oh, I'm doing
Yeah, I know.
But we're gonna get rid of the confusion and just stick with the general terms,
Yeah,
okay?
okay, yeah, yeah.
It smells
Yes.
So is the mesentery, is it deeper to the greater?
No, they are all, they're referring to these membranes as mesenteries. I know, so forget about the mesenteries. Forget about the posterior mesentery, anterior mesentery. Just recall that this structure is the greater omentum. We're not worried. Forget about mesenteries. Forget about mesenteries.
It's really confusing.
Jessica, say it one more time. I'm gonna say it one more time.
Forget about it.
Forget about mesenteries. The greater omentum, lesser omentum.
Yeah.
Mesocolon, mesentery
Mesentery.
proper. That's the only one we're calling mesentery.
That one?
The one
Yes.
attached to the small intestine.
The one that has all the loops of small intestine suspended from
Once
it.
it's on the rat.
No.
And not to be confused with visceral.
Yes.
So it is deep.
I didn't say mesentery.
Yeah, she did.
Mesocolon is mesocolon.
We are going to.
Mesentery is mesentery. Name is connective tissue.
I think so.
All right, okay, I need everybody back. Everybody back. Here's a nice view of the small intestine. These are all the same tube. We don't know if it's jejunum or ileum, that doesn't matter, because grossly, there's no hard and fast boundary between one and the other. In fact, if you look at them histologically, you can see there are distinct differences between duodenum, jejunum, and ileum, but you have to know what those are. That you have submucosal glands in the duodenum, and as we go on, we're going to talk about the length of these structures and what they do, and that becomes help you with your identification. Okay? All right, okay? This also shows you the mesocolon, so large intestine, transverse colon of large intestine with the mesocolon attached to it. And then they pulled up the greater omentum here so you can see all those under structures. Then thing to talk about is the peritoneum. The peritoneum is the space in your abdominal cavity that houses all of these structures. Some of the structures within our abdomen, however, are not included in the peritoneum. They are said to be retroperitoneal. And one of those structures that is retroperitoneal is the kidneys. The pancreas is considered retroperitoneal. And believe it or not, the duodenum is retroperitoneal. But all the loops of small intestine are included in the peritoneum. And here's our colon included in the peritoneum. Here's the stomach included in the peritoneum, kind of, sort of. But the peritoneum, as you see, is this blue line. This is our parietal peritoneum. And then the visceral peritoneum is surrounding each of these organs that's included in the peritoneum. So the visceral peritoneum is really the serosa, the outermost layer of these loops of intestine.
Wait. The visceral is the outermost layer of the loops of intestine, so under the greater omentum.
Yes. So if
Okay.
you take a loop of intestine and you look at the 4 basic layers from mucosa out, the serosa is the outermost covering,
Okay.
and it is also known as
So
the visceral peritoneum.
Peritoneum.
Mhm.
Okay.
Yep.
All right.
Okay? Bladder, retroperitoneal, and sometimes they call it anteroperitoneal. We can refer to it as retroperitoneal. Rectum, retroperitoneal. So really just the loops of intestine and stomach, and a little bit of the liver is included in the peritoneum. there's part of the liver that is so close to the diaphragm that it doesn't get included in the peritoneum. Just that top part right there. All right. So, I should talk about this a little bit before we move on. The peritoneum is a sterile environment. It is aseptic. But our intestine, the lumen of, is anything but, loaded with bacteria. And so there is always the risk of introducing those bacteria into the peritoneum. And when you do that, you develop a condition called peritonitis. And peritonitis can kill you. So it's a very serious thing to have peritonitis. And peritonitis can happen from an appendix rupturing. Like, it's the most common form of introducing bacteria into the peritoneum is the appendix. And you get appendicitis, and then you don't deal with it, and it ruptures. And sometimes you're dealing with it, and it's rupturing right there while you're in the hospital. Sometimes that can happen. Yeah.
What is the appendix primarily used? Just like storage of nutrients? Or
The appendix actually stores bacteria,
bacteria.
and it stores lymphocytes, and it helps to produce vitamin K. The bacteria that are there are in part helping to produce vitamin K.
You can live without it.
You can live without your appendix just fine. You can also live without your spleen.
Really? What is spleen?
I,
It's the graveyard for erythrocytes, right? I knew that.
I had a friend in elementary school who went to get her appendix removed,
Uh-huh.
and while they were in the operation to remove it, it burst.
Yes, yes. So fortunately, they were right there, and so
Yeah.
crisis averted.
Ew.
But if you have all those bacteria now swarming around in this nice clean peritoneum, that's dangerous. You can have a rupture of the GI tract. You can have ulcers along the length of your GI that can perforate and allow those bacteria, that perforated ulcer, meaning it's perforating from the lumen toward the outside, and then bacteria are in your abdomen. And bad surgery, try as they might, you might get introduction of bacteria into the abdominal peritoneum. So these are problematic. So we don't want to get peritonitis, serious inflammation or infection of the peritoneum.
Cure it?
Yeah, you can take
Antibiotics?
antibiotics. Hopefully. Yeah, people die.
Yeah.
Animals die from peritonitis. Because you wouldn't know. Harder to know on an animal. All right, so the first of the structures we're going to delve into a little more closely is the oral cavity, your mouth, as it were, also known as the buccal cavity. Don't get buccal, like I was taught, because some hygienist is going to correct you. It's the buccal cavity. Obviously, your mouth has many, many functions. It houses your teeth, and your teeth are responsible for grinding things or shearing things. Your incisors, your canines are all about shredding and shearing, pulling meat off bones, etc. Your molars, premolars are for grinding. We are omnivores. We eat a multitude of different foodstuffs. We were designed to eat a multitude of different foodstuffs. And the teeth are important in that process. Your tongue is equally important for a couple of reasons. One, it is a very muscular structure, and it has taste buds on it. Remember the taste buds from 232?
Yep.
The 4 different kinds of taste buds. The 4 papillae, and which ones have the taste buds on them. The tongue pushes that food around in your mouth, gets it between your teeth, and ultimately you produce something called a bolus, that is the food mixed with saliva. And that bolus then is sent to your oropharynx, where you have a swallow reflex, and you immediately swallow it, and it's going down your esophagus, whether you want it to or not. Cats, if you were a cat, you could recall it through regurgitation, but we don't have that necessarily.
it's voluntary for them?
They can just bring it back up.
Yeah.
Those little hairballs,
Yeah.
they decide that they want that? I used to-
And then we have the ability to speak. So the tongue is important for speech. In the old days, they would cut somebody's tongue out if they were lying or caught lying or doing something bad. They'd cut your tongue out. You can't speak without your tongue. So you need to be able to speak with your tongue. We have a little bit of something called chemical digestion that occurs in the mouth. That is because we produce saliva, and that saliva from the parotid gland in particular contains an enzyme called amylase. And I think we talked about that in lab, and how your potato chips turn to sugar. Yeah.
This might be a stupid question, but can you swallow without your tongue?
I think you can.
I saw a
In
girl-
fact, there was an image of a woman who had lost her tongue,
she had to
and
swallow like
you
this.
have to sort of send things to the back.
Like what- she has
And
to
then you
lift
got
her
your
head up.
swallow reflex from the oropharynx.
Okay.
Yeah, but it would
Also
not be
swallow
as
your tongue.
easy, not as effective for
Yeah.
sure, without your tongue.
You can also swallow your tongue if you're not like really careful.
Yeah, well, it has to be attached, so it.
Yeah, but it's still a thing.
It would block the passageway for a moment.
Yeah.
What else do we have? Of course, taste, we talked about that. And the salivary glands dump into the mouth. Remember, the parotid gland dumps into the buccal cavity, the buccal surface, and your sublingual and submandibular glands empty into the mouth underneath the tongue. These, we are not asking you to identify specifically, but know that they empty under the tongue and that the parotid empties into the side. What else do we have in the mouth? We have the uvula, has multiple functions. Mostly it is about keeping things from getting up into the nasopharynx. It also is part of that gag reflex, so we don't get things down that we don't want to go down. There's a little bit of immune response by the uvula. Another thing that we have in the mouth that I didn't point out, the hard palate and the soft palate. The hard palate has ridges on it called rugae, and that is all for driving that bolus back to the oropharynx so that you can swallow it. But the hard palate, of course, is also to prevent food from getting up into the nasopharynx, in the nasal cavity. The tongue is attached via a structure called the frenulum. Actually, it's attached in multiple places because the tongue is not just one muscle, it's a collection of smaller muscles, and they are moving in multiple directions, so our tongue is super mobile. Like we can twist it and turn it, fold it, and crunch it, do lots of things with the tongue. The tongue is covered with stratified squamous epithelium. Clearly, that makes a lot of sense because it takes a lot of abuse. The hard palate is stratified squamous epithelium. There's a little bit of keratinization on the hard palate. We have the gums surrounding teeth that is a mucosal membrane stratified squamous epithelium with a little bit of keratinization around the teeth themselves. You remember the special joint that is formed between the teeth and the mandible and the maxilla? Called the comphosis, right? Special, the only place that we find that. And we'll talk about the teeth here in a moment. Anything else we need to talk about here? Oh, the palatine tonsils, yeah, don't forget them. The lingual tonsil is on the back side of the tongue, so we don't see that in this image.
So the soft palate is kind of that like skin that you see behind the uvula, that like
Yeah.
that tissue
Where the
that's
where
right.
the palatopharyngeal arches. Mhm. And this is the glossopharyngeal arch, so these are considered soft palate. And then the oropharynx is back here.
Perfect.
Yeah.
When people remove their tongue tie, are they cutting the frenulum?
Frenulum.
Frenulum?
If
Call it a
they're gonna remove your tongue?
frenulectomy.
When people have a tongue tie,
Yes, they nip this. Yeah,
Both my boys have them.
yeah. I was same, but we had when I was a little girl, we had Dr. Wise who came to the house, and he tipped my head over the arm of a chair and asked me to open my mouth, and he was going to nip my little frenulum.
Oh my
I don't
gosh.
think it actually happened.
Oh my god.
Because
How
I'm
old
still
were you?
tongue-tied. I don't remember, like 5, 4
Oh,
or 5.
that's
I know, really,
terrifying.
right? And Dr. Wise had Tourette's syndrome, and his Tourette's was expressed with,
Oh no, that's like that's
he was the
trauma.
sweetest man, but I never forget Dr. Wise and his Tourette's. All right, so what else are we looking at? So here's a little closer look at the tongue itself. As I mentioned, lots of muscles combine to make the tongue. It is controlled by the hypoglossal nerve, because the hypoglossal nerve is considered motor and drives the movement of your tongue. You might remember that the tongue has all of these papillae on it, the circumvallate or valley papillae here with the most taste buds on them. You have a combination of filiform and fungiform on the surface of the tongue, and those filiform, remember, they don't have any taste buds. They're all about texture. And the fungiform, some taste buds, and then we have those that are surrounding the edges called the foliate, and these have taste buds on them, but apparently they disappear as we get older, and that is a perfect explanation for why when kids have all these taste buds, they have less desire to taste certain things, right? They're more discerning in their tastes. And then as we lose those taste buds, we'll eat more and more stuff because we're not worried about the taste so much, or we develop a taste for it. Let's see, what else? Looking at our teeth, by the way, these are my teeth.
Really?
Yep, those are my
You
teeth.
inserted your own x-rays?
Pardon me?
You inserted your own x-rays?
Yeah.
So we can see some teeth.
Did you add Dennis?
Yeah,
Oh.
he's my buddy. I've been going to him for 25 years, so, yeah, we're getting old together. And so I can ask him any dental question I like. He's great. So yeah, you can see my teeth have a lot of fillings, and most of those fillings were put in when I was a kid, because we had well water, no fluoride. Toothpaste didn't have fluoride in it. White knuckle ride to the dentist. The gauge of the needle was probably a 20, maybe 18. Oh, painful. At least we had Novocaine.
Yeah.
Phew. The drills were slow. You can see I suffered. I mean, I still have all my teeth, which is really good. You want to keep your teeth. You want to keep your teeth, you have to take care of your teeth. So a tooth is a very special structure. Remember me telling you a tooth is not skeletal. It's not bone. They are unique. They are made of unique tissues. The tooth itself has regions. The crown, neck, and root. Crown is the exposed portion. Neck is where the gingiva engages with the tooth. And then the root is anchored in the bone. Right? Crown, neck, and root. The crown is made of enamel. That is the strongest material in the body. And you want to keep that enamel, although as we get older, it does wear. It does. So take as good care of your enamel as possible. Deep to the enamel is the dentin, and the cementum is the tissue that is surrounding the outside of the root and engaging with the alveolus of the mandible and maxilla. And I say this is alveolus because it's a pocket, right, that the tooth is housed in. There's our cementum, and there's our periodontal ligaments that are holding the tooth to the bone. We have deep to the dentin the pulp cavity, and the pulp cavity is housing our blood supply for the dentin because it's a living tissue, as is the cementum. The only one that is not living tissue on the tooth is the enamel. We have an apical foramina here where our nerve supply, our blood supply enters to the root of the tooth, traveling up the root canal to the pulp cavity. When you get a root canal, they're going to destroy all of that sensitive tissue. And so you no longer have any nerve innervation, but usually when they do a root canal, they're going to replace that tooth with an insert of sorts, right? Or a crown, maybe a crown. Yeah.
Can your tooth survive without the nerves and blood vessels and that kind of stuff? Like if you get a root canal and you don't replace the tooth?
I think you can. It's as long as you take care of the gingiva, that you don't don't get bacteria down in. Yeah.
Yeah, whenever you go, I think they say that you have to get like a crown over top, otherwise the tooth is going to decay.
Yeah. Yeah, so they're going to take the tooth and they're going to put your crown on, or leave the tooth, do the root canal, and then put a crown on top of it. Thank you. All right, so we got lots of different kinds of teeth in our mouth. We have 4 incisors. They're sharp-edged. You all know your incisors, front teeth. We have 2 middle incisors, 2 lateral incisors. They are surrounded on either side by our canines. More shearing, so all of these teeth are sharp and designed for shearing and tearing. The canines are followed by 2 premolars, first premolar, second premolar, and then 3 molars. These are also called bicuspids, and these are called tricuspids. Not all of us have all these same teeth, right? So when we get old enough, like in our teens, we might have our wisdom teeth erupt. Do you all have your wisdom teeth?
Not anymore.
Not anymore, you had yours all taken. Some people don't have enough room in their mouth, and they will extract the wisdom teeth so your other teeth will have plenty of room. I lost a 12-year-old molar And so I had plenty of room for my wisdom teeth to fill in the space. It's very important that you take care of this gingiva. And to take care of the gingiva, you should be flossing. It doesn't cost much to buy floss. It costs everything to lose your teeth. So the way to avoid losing your teeth is to make sure that you floss in between each of these crowns, and you kind of beat up the gingiva with the floss.
Keratinize it?
Yes, exactly right. You keratinize it. You make it a little tougher by hitting it. And at the same time, taking whatever is sitting on that surface away. Yeah, with your floss, yeah.
One of your questions on the worksheet, you asked to list 3 features of the articulation that holds the tooth in place. And I was thinking, the cementum, is that what you were thinking?
Yep.
That's
Mhm.
holding it in place? And then the ligaments,
That's right.
that's also holding it in place.
Yep.
But what's another feature?
The gingiva.
Oh, the gum itself is
Yeah.
holding it in place.
Well, it's not
Okay.
really holding it, but it's preventing things from getting down. It's a feature.
Okay, it's a feature that's part of the articulation, is the gingiva. Okay.
Yep. And then you have your apical foramina. So another feature, allowing your nerve and
Holding it in
blood
place?
supply. Not necessarily holding it, but
It's a feature of the articulation
yes,
that holds the tooth in place. Okay.
for sure, the periodontal ligaments. For sure. Mhm. Then we have salivary glands. We are familiar with our 3 basic salivary glands. We've identified external salivary glands, the parotid gland entering into the buccal cavity. We have our submandibular and sublingual salivary glands, and each of them has a unique feature. This, remember, is our more serous producing gland. This is our more seromucus producing gland, and this is our more mucus producing gland. And you can see all of those little ducts that are ending up underneath the tongue, so you can take your heart's desire. The saliva that these glands produce does more than just moisten the food. There are lysozymes that are in the saliva, which is fabulous because if you're putting food in your mouth, you know it's not clean, unless it's been boiled or it's been baked to death. But everything else, the fresh foods, fresh veggies are all going to have bacteria on them. So nice to have some lysozymes available, some antibodies available. And as I said earlier, the parotid gland in particular is known for producing amylase. And so you actually first start your chemical digestion of carbohydrates in the mouth. The other thing that your mouth does with these teeth is something called mechanical digestion, right? The mechanics of chewing is considered your mechanical digestion. The chemical digestion is done by enzymes, for the most part. And of course, the hydrochloric acid that we'll talk about in a moment. So we got those extrinsic salivary glands. They discovered not too long ago tubercle salivary glands, give you a little link there, and they're up near that auditory tube, near your eustachian tube. I think we looked at that when we were talking about the respiratory system. Remember, I pointed out to you, there's the tubal or tubarial cell gland, okay. And then we have, oh no, those weren't the glands, those were, they were tonsils. Same idea, these are similar in their location. We have also got some salivary glands linked to the lips, the palate, tongue, and they're constantly working. Right? Your parotid salivary gland, your sublingual, subdominant, is kind of controlled by your hypothalamus when you get hungry, because they've got salivary nuclei.
Intrinsic salivary glands is mostly serous.
The parotid is mostly serous.
No, I was thinking the intrinsic.
Yes,
The ones that
probably.
secrete all the time.
Yeah,
Yeah,
probably.
this is serous.
Although I don't know for a fact.
Okay. It seems to make sense.
It makes sense because they're the ones that are keeping things nice and moist.
Yeah.
Yep, so here we go with our swallowing reflex. Occurs when that bolus gets to the oropharynx or hits that soft palate. Boom, it's going down the esophagus. The esophagus is literally a conduit. It's carrying that bolus from your mouth down to the stomach. There are skeletal muscles surrounding it in the upper reaches, and then we have a transition to smooth muscle as the esophagus hits the stomach. So literally just a conduit. There have been discussions about whether it's considered mechanical digestion. There's clearly no chemical digestion going on in the esophagus, but is the peristaltic movement considered mechanical digestion? I'm not so concerned about that. I do want you to know that it is skeletal muscle up here, smooth muscle down here. It takes very little time, 4 to 8 seconds for that bolus to go from here to here. And it can do that even if you're standing on your head. So the peristaltic movement of the skeletal muscle and then smooth muscle is going to move that bolus into your stomach whether you are head up or head down. Interesting, right? The stomach or the esophagus has an upper esophageal sphincter that's preventing your gastric juices from getting into your mouth. It's preventing food from getting brought back into your mouth. And then you have a lower esophageal sphincter, which is preventing gastric juices from getting up into the esophagus. If they get up into the esophagus, this is going to stop them, ideally. But there are some people that develop a cough, which I had for a while, and that cough is the result of this eruption. So it's an upper esophageal, what's the word I'm looking for? Gastroesophageal reflux, so it's upper reflux condition. But you can handle that by taking some omeprazole to reduce the gastric acidity of the stomach.
Is that heartburn?
No, it's heartburn.
It's like acid reflux.
Gastric reflux is heartburn, yeah. So your diaphragm has 3 holes in it. Do you remember this from 232? We got 3 holes. We got the esophageal hiatus, the aortic hiatus, and the inferior vena cava hiatus. All 3 structures have to be able to pass through the diaphragm. Here's your esophageal hiatus. And when you have a opening, a relaxation of that hiatus, your stomach can be pushed up into your thorax. And that's called an esophageal or a hiatal hernia.
Sounds
That's the name of
fun.
that, a hiatal hernia. So we are well familiar now with the histology of the esophagus. Remember, the esophagus is stratified squamous epithelium. We have a big lamina propria. We have then got a muscularis mucosa, and then a submucosa, and then we have our external, muscularis externa and serosa, or excuse me, adventitia around the esophagus because it's not in the abdominal cavity. And that's pretty much all you need to know about that. I would look at that again if I were you before the lab exam. You never know what's going to show up on your lab exam in terms of the histology of the esophagus. We mentioned this thing called peristalsis, talked about it before. It is the very, very rhythmic and systematic movement of materials down the length of the tube. And this is a nice way of imagining it, where you have, your circular layer of smooth muscle and longitudinal layer of smooth muscle that are working in coordination with each other, as this says, like squeezing toothpaste from the bottom of the tube. So we squeeze, push the bolus forward. This then relaxes, so we can push that bolus forward. Then we get a squeeze again, so the bolus gets pushed up here. Squeeze, push the bolus here. Squeeze, push the bolus here. All the way down the length of the tube. Very systematic. But as well as the peristaltic movement, we have something called segmentation. And if you can imagine, that bolus sitting right there is now going to be kind of mushed on by the smooth muscle in place. So we have some mashing, more mechanical digestion beaten up on that material that is in the lumen of the tube. So this segmentation is mixing up the chyme that's coming from the stomach into the small intestine and churning up, kind of, in one case, this segmentation is important for emulsifying fats. And we have to emulsify the fats because we have to reduce the big globules of fat to small, tiny globules of fat so we can get bile salts around it so the enzymes can get in there and reduce those triglycerides to their base components. So then we can repackage them. Maybe you see what the stomach does, or the enterocytes do. So emulsification happens along the way of mashing this material up and pushing it down the length of the tube. The stomach. So from the esophagus, we end up in this large pouch. They call it a holding tank. I don't think of it so much as a holding tank as I think of it as this big mixing vat. Remember do you ever seen how cement trucks are rolling around? They got that big thing and it's constantly turning like this. Well, think of your stomach in terms of that, really. Although it's not rolling this way, it's got 3 layers of muscle: longitudinal, circular, and oblique. And that gives you nice, really comprehensive compression. So we send this bolus from the mouth, barely been beaten up on, and by beaten up I mean chewed on and mixed with some saliva, shunted down the esophagus, it hits the stomach. And the stomach has several regions. Here's our cardiac region, or lower esophageal sphincter, cardiac sphincter, and then the cardiac region below that right here. And then we have a fundus. This region of the stomach is called fundus. And we have the body of the stomach, and then we have this region known as the pyloric region, broken up into antrum, canal, pylorus, and pyloric sphincter, where in the stomach we produce gastric juices. And the bulk of the gastric juice is hydrochloric acid. So you get gastric juices with hydrochloric acid mixed in it that makes that fluid very, very acidic. What else happens is that the entry of food into the stomach stretches smooth muscle. What happens when you stretch smooth muscle? It contracts, right? It constricts. And so you fill your stomach up, you've stimulated these smooth muscles along with gastrin, which help with the stimulus of skeletal or these smooth muscle contractions. And these smooth muscles start to contract, and that pushes that food around in the stomach and mixes it up with that gastric juice, and you produce a substance called chyme. That's the fluid that is the result of this mechanical and chemical digestion in the stomach. The chemical digestion is coming from the hydrochloric acid, and the mechanical digestion is coming from the mashing of that material that entered into your stomach. All right. And so we have food entering in the stomach. The stomach is lined also with rugal folds, the rugae. You've heard of that because we looked at it in lab. And those rugae just add surface area to the lining of the stomach. So you get as much out of that region as possible. Peristalsis is considered the same movement through the stomach as in through the small intestine. The chyme that is the result of this chemical and mechanical digestion is going to end up in this region of the stomach called the pyloric region, and then it's going to be squirted out in 2 and 3 ml volumes into the duodenum. Little bits, 2-3 mils squirted out regularly from the stomach to the duodenum. That way your duodenum doesn't get overwhelmed, and there's plenty of time for your pancreatic enzymes and your bile to mix with the chyme that is delivered from the stomach. It takes quite a while to process your food, 24 to 36 hours. 4 hours to get it to move from your stomach and fully into the small intestine. Yes, Lindsay?
Oh gosh, I lost it. Oh, so we have the gastric juices that are like the whole reason why we've got chemical digestion.
Mm-hmm.
How do we keep those in there?
They're in the stomach.
Yeah.
They
So,
stay
like,
there.
When it's,
The esophageal, so you have your lower esophageal sphincter.
no, I'm talking about when it's like shooting the chyme out.
They don't keep
I
it.
would imagine that some of the gastric juices come
That's
out.
chyme is the gastric juices mixed with the food.
Okay, so how do we still have, like, where do the gastric juices come from? That's my question.
The lining of the stomach.
Okay,
And we're going to talk about those
Okay.
cells next.
so I'm getting ahead of myself.
Yeah, yeah. All right, so she's worried about how we're going to keep it in the stomach. Well, the lower esophageal sphincter prevents it from going up here, and the pylorus prevents it from leaving too rapidly.
Okay.
So that pyloric sphincter, 2-3 mils. And 2-3 mils is a really small volume.
Yeah.
Really tiny. Yes, go ahead.
So most of the time, if you like puke, it's it's coming just from the stomach, not anything past.
Generally, it's from the stomach, but if you're really sick, you could be bringing food from the duodenum back up. And that would be the bile, that greenish color, yellowish greenish color, and that really nasty bitter bile is bitter. So if you're really vomiting and you're really bringing it up, yeah, you might have some bile mixed in there.
People get like NG tubes, and then it's like green, that's what.
Yeah. 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 Oh, that's the end first one. Doing good. By the way, I haven't told you yet, but I'm really proud of you guys.
Thanks.
We're proud of you too, Heather.
I know how hard you work. I know how hard it is. So,
Thank you.
do well, and that's why I'm going to give you that chance. All right, so let's look at the stomach mucosa and talk about how it works. So remember, we looked at the esophagus and the epithelium of the esophagus, the stratified squamous epithelium, yeah? And then we had that really sharp transition. There's one of those clear boundaries. We went from stratified squamous in the esophagus to columnar epithelium in the stomach. And then we talked about how the stomach lining grossly has rugal folds. But if we look at it more closely, we can see these things we call gastric pits. These gastric pits lead to gastric glands. Gastric pits lead to gastric glands. This is all mucosa. Here's our muscularis mucosa. So there's our boundary between mucosa, submucosa, our 3 layers of smooth muscle surrounding the outside of the stomach. But this is what we're focused on right now, the gastric pits that lead to gastric glands. And these gastric glands contain several different kinds of cells. As this says, each pit gives rise to 2 or 3 glands. Here's a histological image of the lining of the stomach. There's our columnar epithelium. Here's a pit. Here's a pit, 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 pit. See all the pits? All right, we've got lots of pits. And these pits lead to the glands. So down here are the glands. All of these are the glands from the pits. This is from Histology Guide. This is the epithelium covered with mucus. Here's a pit, here's a pit, here's a pit, there's another pit, and these are leading to the glands. Those are all glands. There's a little lamina propria there, a little lamina propria there, there, all lamina propria. And so we have the pits leading to the glands, and in the glands we have very important cells. All these cells have different jobs to do. So let's look more closely at the different cells that are contained in the pit. Surface is covered with mucus, and that mucus is created by these surface mucus cells. And why do we need mucus in the stomach? Anybody take a guess?
Protect the epithelium from the gastric juice.
Right, if we're making hydrochloric acid in the stomach, we have to have a pretty good mechanism for taking care of those cells. They still get beat up. They're going to be replaced every 3 to 5 days. But in the meanwhile, they got mucus that's covering them. That mucus is covering the surface. These are our mucus, surface mucus cells. Then we also have down here within the neck of the pit, these mucus neck cells. It says it secretes acidic fluid. They don't really know why it's more acidic or what the function of that acidic mucus is, but we know that they exist. They also believe that these mucus neck cells can serve as stem cells to replace these guys. Which is great, because that means that we're constantly replacing in a very logical progression up and out. Then we have these guys, these parietal cells. These parietal cells secrete some very important substances. One, they are capable of making the hydrochloric acid that makes the stomach juice very acidic. They produce intrinsic factor, and intrinsic factor is essential for making vitamin B12, and vitamin B12 is essential for hemopoiesis, for actually erythropoiesis, for making hemoglobin. So we want to keep that in mind. And they produce this hormone called ghrelin, and it's an appetite stimulating hormone. Let's think about, why would we want to have a hormone that is an appetite stimulant being produced by cells that are in the stomach.
Maybe the stomach knows it's empty, and so it's like, well, now you can eat.
Alert you?
It's just guess. I'm guessing.
You're on the right track.
Okay.
So if we have parietal cells making HCl, hydrochloric acid, this is the result. This is in response to another hormone called gastrin, which was released at the lower parts of the stomach, travels through the circulatory system, and then stimulates these parietal cells to make HCl. Well, if you're making hydrochloric acid, don't you want to have something to work on? So perfect, right? That means that your stomach is taking care of itself. You produce this appetite stimulating hormone, and then you got food coming in. And this whole thing is all reflexes.
Right.
The brain. Yes.
So what if you won't/can't eat
What
at
if
the time?
well, then you risk burning. Right, but you fortunately have lots of mucus. So people who are anorexic, problems, burning, yeah. So the parietal cells are seen here. Here's our mucus, these are the glands, and these are the parietal cells. And these guys down here are chief cells. But these parietal cells are the ones that are making hydrochloric acid, intrinsic factor, and the ghrelin. Very cool. And then we have these cells called chief cells. So we know about the mucous neck cells, the surface neck mucus cells, the mucous neck cells, the parietal cells, these chief cells. They secrete an enzyme, prozyme called pepsinogen, and they also produce gastric lipase. So you got lingual lipase, and I didn't mention that, did I?
I think you said something.
Lingual lipase is produced by the tongue, but it's not activated until it hits the stomach and gets activated by hydrochloric acid. Kind of weird. And then we produce gastric lipase. So we do have a little bit of chemical digestion of lipids. And by chemical digestion of lipids, I'm talking about reducing them from big structures to smaller ones, from big globules to smaller globules, along with that mashing and churning of the stomach content. All right, so we got this pepsinogen and the gastric lipase. Now, this pepsinogen is not an active protein or protease. Why wouldn't we want to produce in those chief cells an active protease? So we don't, why do we need all these extra steps? Why do we make a prozyme or a zymogen, not a protease?
I have a guess. That it's so that when it starts to digest proteins, it'll digest the food proteins and not the proteins in
Perfect.
your...
Exactly. Your cells are loaded with proteins. There's enzymes in there, lysozymes, you got all these kinds of proteins inside the cell. You don't want to produce a protease that's going to digest the cell itself. So chief cells make a prozyme or a zymogen, call it what you like, that is going to be converted to an active protease when it's exposed to hydrochloric acid. Yeah, so clever, so clever. So the parietal cells make the hydrochloric acid, the chief cells make pepsinogen, that's then going to get converted to pepsin as it's exposed to the parietal cells' hydrochloric acid. Down here, in the deepest recesses of our gastric gland, we have enteroendocrine cells, that secrete gastrin. And gastrin is going to get the rest of everything going. Stimulates stomach motility, stimulates the release of the parietal cells, the chief cell secretions, relaxes the pyloric sphincter. Makes sense, doesn't it? And now if you've got all this going on, you're producing this fluid, you gotta move the fluid. You can't have it all sitting there in the stomach. You gotta move it. So it's gonna be released very carefully, 2-3 millimeter at a time through the pyloric sphincter. And, as an added bonus, it's going to prevent things from getting up into your esophagus by constricting the cardiac sphincter. Very cool. They think that these enteroendocrine cells may also serve as stem cells, so they're constantly replacing these guys, and these guys get beat up and they get replaced. How does the parietal cells do this? How do they make HCl? All right. You might recognize this little puppy. Anybody? Anybody? Anybody?
CO2 to carbonic acid.
Carbonic acid is carbonic acid is made with combining CO2 and H2O. What's the enzyme that's responsible for doing that? Carbonic anhydrase, very good. This CO2, where do you think it comes from?
Tissues.
Everywhere. Comes from the cells themselves, comes from the blood, comes from everywhere, because every single one of our cells is making CO2. If it's respirating, it's making CO2. So we also have all water all over the place. We are water-based animals. So we take the CO2, this parietal cell takes the CO2 from the blood, or wherever, combines it with water from wherever, makes carbonic acid. The carbonic acid dissociates via something called an antiport. This is the hydrogen potassium ATPase. It is an enzyme, but what it's actually doing is it's dissociating the carbonic acid and producing bicarbonate and hydrogen ions. The bicarbonate is shipped to the blood, and it is swapped out with chloride. We heard of this before, kind of, what was it called?
Chloride shift.
Chloride shift, but what's the difference? There's a difference here.
Chloride. Leaving the blood? Wasn't it going in?
Keep going, keep going. In the lungs,
Yeah. It's the other way.
Reverse, it's opposite,
in the lungs,
right?
It's towards the
Exchange.
lungs.
there's an exchange, back and forth, right? The bicarbonate is shipped off and the chloride shipped in, and then at the other end of the cycle, the bicarbonate's brought back in, the chloride shipped back out. In this case, once the bicarbonate is shipped here, it stays in the blood. In this case, once the chloride is shipped here, it is moved into the stomach. This is called an alkaline tide, whereas the other was called a chloride shift. And that was what I meant, back and forth, right? In this case, there's no shifting. It's just we move the chloride from the blood and we move the bicarbonate into the blood. And this then is what this antiport does. So it has already produced the bicarbonate, that gets shipped into the blood. We swap it out with chloride. The chloride just passes right through the parietal cells. They ship them into the stomach lumen. The carbonic acid is broken up into bicarbonate and hydrogen ions. The hydrogen is shipped into the stomach, and boom, positive, negative, opposites attract. You have hydrochloric acid. How about that? It's cool. And so we can go from a normal pH in the stomach of 1 or 2 to as low as 0.8. Vicious.
Wow.
Very acidic. And so you can imagine if you have that erupting from your stomach into your esophagus all the time, you have chronic heartburn, you cause damage to the lining of your esophagus. You can get esophageal ulcers. You can get esophageal cancer. And in part, it could be the result of this acid ending up in your esophagus. The big deal about this is, of course, it helps in our digestive process. It helps with chemical digestion. It helps to denature the proteins of the foods that we've eaten, the enzymes that we've ingested, because we were eating enzymes as well as producing them. It helps us, I love this part, that we don't necessarily have cellulase, we don't have an enzyme for breaking down cellulose, but we do have hydrochloric acid. It helps to break down those plant cell walls. It helps to denature the proteins, all those big heavy proteins, the meats that we eat. Again, it converts this pepsinogen into pepsin. It does activate this lingual lipase and the gastric lipase. And, do you remember this from 232? We went ferrous to ictus, right, when we were talking about making hemoglobin. And so here's where we get converting ferric to ferrous.
It's interesting to me that pepsin and the lingual lipase can exist in hydrochloric acid.
Yes.
That they're not being.
We need the HCl in order to convert pepsinogen into pepsin.
convert. I
Yeah.
mean, it's not denaturing those proteins.
No, it's,
It's
yeah.
just denaturing other proteins.
Yes.
So when your pH goes below like 0.8, is that ketoacidosis?
Or is that something?
No, that's, like, we don't deal with consider acidosis in the stomach because it's already fairly acidic.
Okay.
Acidosis, metabolic acidosis would be an overall condition.
Oh, okay, gotcha.
Yeah, but thinking. All right, so here's what happens. Chemical digestion by the stomach. Remember, our parietal cells are responsible for producing hydrochloric acid. Our chief cells are responsible for producing this pepsinogen. It's a precursor to the functional enzyme that we need for the beginning process of denaturing proteins, for reducing proteins. So here's our pepsinogen, here's our HCl. The HCl causes this peptide portion of the whole to peel off, and we're left with pepsin. Pepsin is an active protein, active enzyme, and it can work on our dietary proteins and reduce them to tripeptides and dipeptides and even amino acids. But generally speaking, they're a little larger than single amino acids. That happens down in the walls of the small intestine. So, parietal cells, HCl, chief cells, pepsinogen. Pepsinogen gets reduced to pepsin. Now, the cool part is that this pepsin is considered autocatalytic. In other words, once we produce some pepsin, it can continue to reduce more pepsinogen to pepsin.
So it digests itself.
Yeah.
It digests its earlier
Yes,
version.
it's an earlier version of itself. So you start out with one, you can have multiples working on the proteins at the other end. Yeah. So the stomach itself, big important, I don't think of it as a storage vat like the slides, but I think of more of it as a mixing vat. Because you put food in and then you move it through, but in the meanwhile you got to mix it up with these gastric juices. So what does the stomach do besides the mixing? There is a little bit of absorption that occurs within the stomach. As you can see here, there are certain things that are readily absorbed through the stomach: lipid-soluble drugs, alcohol, and aspirin. Thank goodness. My favorite is Excedrin. I love that stuff. And I love the fact that you can take an aspirin and 10 minutes later feel the effects of it because it's readily absorbed right from the stomach.
Don't they say it can be hard on the stomach? Don't
It
they
can
say
be.
it can be really hard on the
Yeah.
stomach? And
So you want to have
can
food in it.
contribute to ulcers?
I don't know.
I feel
I
like,
think it can be irritating,
yeah.
inflammation-wise, but generally they're not so much the stomach as they are the liver.
Oh, okay.
Liver and kidneys
Yeah.
for these NSAIDs.
Right.
Yeah, I have one in my pocket right now that I didn't take with food this morning, now I can't take it. Empty. All right, so let's think about what else the stomach does. Remember that mucus protects those epithelial cells, and that we have those mucus cells that, contain alcohol dehydrogenase, which can convert our ethanols to acetaldehyde. The alcohol absorption is readily known to everybody, I'm sure. And you also know that if you're going out for an evening and you know you're going to be drinking, that you want to have a full stomach. And of that full stomach, you want to have some lipids, because lipids slow down the absorption of that alcohol. So make sure you have a good stomach content, slow down that absorption until that food gets into your small intestine. Speaking of the small intestine, what do we have? 3 regions of the small intestine, yeah. And as this says, the name is a bit of a misnomer in that, yes, it has a small lumen. That's where the name small comes from, but it is quite large in terms of length. If you stretch it out, approximately 20 or so feet, depending on the size of the individual, obviously. Somebody smaller would have shorter, somebody larger would have more, but in general, 20 or so feet of small intestine. So if you were to take it all out, we're talking a lot is jammed into that space. We start out with the duodenum. We go to the jejunum and then the ileum. There is a mnemonic there. Does anybody need that? Yeah? And you can say duodenum or duodenum, I don't care. I've never heard jejunum said any other way, or ileum. Back to spelling. Note ileum with an E versus ileum with an I. Where's the ileum with an I?
Hip
Oh,
bone.
your
Pelvis.
ilium.
Your ileum. So spelling here becomes important. You're writing notes. You call it your part of the intestine the ileum with an I. Somebody's going to be like, how did the skeletal system get in here? Yeah. What's happening with the skeletal system? Got to be careful about that. All right. So the duodenum, approximately a foot, 12 inches. What's the function of the duodenum? Well, it's receiving chyme from the stomach. It is also receiving from the pancreas pancreatic enzymes. And it's also receiving from the liver and the gallbladder bile. Bile, by the way, is stored in the gallbladder. It is produced by the liver. Gallbladder stores, liver produces. You can live without your gallbladder too. Appendix, gallbladder, spleen. But it's kind of nice to have it because if you do eat a big fatty meal, you got that extra bile. And bile is essential for what we call the emulsification of fats. Taking big globules of fat and reducing them to tiny little globules that enzymes can get in and work on and reduce the triglycerides to their base components, glycerol and fatty acids. And we use fatty acids for energy. We can turn fatty acids into glucose. So you're all sitting there right now, nice and quiet. Your glucose is being spared for two other cells. What cells need your glucose most? Neurons and? Everybody forgets this one.
Heart?
Red cells. Red cells don't have a nucleus.
Right.
They got no mitochondria. The only way they can make energy is glycolysis. So they need glucose because they can't reduce it to, yeah. All right, so we got the duodenum or the duodenum, short, gets the material from the stomach, and the Brunner's glands, those submucosal glands, are important because they produce an alkaline-rich solution, substance, basic, bicarbonate-based substance that then is going to raise the pH of the fluid that's coming from the stomach. Because while the parietal cells are happy in that acidic environment, chief cells are happy in that acidic environment, the duodenal cells are not. They don't want to be bathed in acid. They want to be bathed in a neutral substance. So we got neutralization of the stomach acid by the submucosal glands. We got pepsin is now done its job. It's going to be inactivated because of alkaline environment. We've had emulsification happening in the stomach, and now it's going to continue throughout the process of peristalsis and segmentation. Remember me telling you about how these boluses of food are sitting in regions of the small intestine, and the small intestine is just doing this, kind of squishing it around, mixing it up, emulsifying things. And you got your pancreatic enzymes being delivered to the small intestine, to the duodenum from the pancreas. The jejunum is where the majority of digestion and absorption occur. The jejunum is not as long as the ileum, but it's the one that does the vast majority of the work. And we're talking digestion as in chemical digestion and a little bit of mechanical, the peristaltic action, the segmentation. But the absorption is super big in this region where we have enterocytes producing enzymes. We got brush border enzymes. We got all of this moving of the materials from the intestine into the circulatory system or the lymphatics via lacteals. And then the ileum is the last part, still some absorption, but we're going to see a thickening of the material that's passing through the ileum, and that material is the leftover, the waste that was left behind from the absorption in the jejunum. And so in the ileum, we start to see an increased number of lymphatic nodules called Peyer's patches or MALT, mucosal associated lymphatic tissue. And we see not so much absorption, right, because much of it has been absorbed, but a movement of the materials through, so still some absorption, but not nearly as much. And as you see here, we're going to get that vitamin B12 taken up. We're going to reabsorb those bile salts and put them back to use again. We take them into pieces and reuse them. Here's an image I like to share with you of where the pancreas is located. So we can't see it here, but it's tucked up underneath the stomach and underneath this transverse colon, so that it can continue connect with the duodenum, right in this region right about here. And so the pancreas has regions. There's a tail, a body, a neck, and the head of the pancreas. The pancreas has a major pancreatic duct here and an accessory duct here, both dumping into the duodenum. At this point, you got your duodenal papillae. You have, unfortunately, it's not showing you how the bile is delivered via the common bile duct, but we would have something called the ampulla of Vater right here. An ampulla is an inflated structure. They still have ampullas for delivering certain drugs. Has anybody ever seen one in the course of your work? Little glass things. It's got a narrow neck and inflated. They're quite delicate, and they probably were used a lot, like in the 1800s, early 1900s, before we started to produce vials. You snap off the top and you got your fluid drug inside. So anyway, an ampulla is, as I said, an inflated structure. And we have an inflated area where the common bile duct joins the major pancreatic duct to deliver those substances to the duodenum via the papillae. Doing good. So earlier we looked at the overall lay of the land of the tube. Remember, we had those 4 basic layers: mucosa, submucosa, muscularis mucosa, or muscularis mucosa, submucosa, and then your muscularis externa and your serosa of the basic structures. But in one of those, I pointed out to you that we have these permanent ridges along the inside of the tube, right? The face, the lumen, here's the lumen, the space. And we have these permanent ridges. They're called the plica circularis, or circular folds. They are permanent. They exist all the time. They increase surface area. They're covered with the mucosa. And the mucosa is covered with villi. And the villi are covered with columnar epithelial cells. So we have multiple regions, multiple mechanisms by which we increase surface area. Because the goal is to get as much out of that food as possible. We want to get as much of the nutrients, as much of the benefit from the money you spent, going to, all those things. You gotta go to the store, you gotta buy it, pack it up, and then take it to home, put it away, and cook it. Takes you 5 minutes to eat it. Isn't that frustrating? So we have multiple mechanisms for increasing our surface area. Lots of surface area, as you see here. Lots of surface area. And these plica circularis is one mechanism for doing that, providing the base for the mucosa, for our villi, and for our columnar epithelial cells, which do all the work. And here's a nice image of just what we were talking about. Here's the fold, and here is our mucosa. And what's beneath the mucosa? The submucosa. And there's a lamina propria that's tucked into this mucosa. Submucosa with its blood vessels and nerve supply, and then our 2 layers of muscle and our serosa on the outside. And these plica circularis covered in mucosa. Let's look at a mucosa more closely, and we can see we have gastric or intestinal gland. We have our submucosa surrounding, and the blood supply. This is lamina propria, there's submucosa under here. Lacteal, good blood supply coursing up between each of these villi. I like this picture even better. So in the stomach we had gastric glands. In the small intestine we have intestinal glands. You might hear them referred to as intestinal crypts too. Same idea. It's just the deep infolds of our villi. There's a villus, there's an intestinal gland. Another villus, intestinal gland. And it could be confusing, but you have to remember these things are 3-dimensional. So a villus has columnar epithelium covering all of its surfaces. It's not just a flat 2-dimensional structure. It's rounded, the tip, columnar epithelium. Just hang on with 1 second, just 1 second. Along the length of our small intestine, we're going to have columnar epithelial cells. We're We're now going to refer to them as enterocytes because they're in the intestine. We have a lot of goblet cells producing mucus, keeping things moving down the length of the tube. We have tucked up in the lamina propria the lacteal. We have arterial blood supplying the enterocytes with what they need. We have venous blood that's going to carry those nutrients that are extracted from the food and delivered to the circulation back to the inferior mesenteric artery, or vein, the superior mesenteric vein, and to the portal vein, and off to the liver. We're going to keep in mind that we have lymph nodules. We're going to keep in mind that we have some cells deep in our intestinal glands that are producing hormones. And we're going to keep in mind that we have some ability to produce some enteropeptidase. This is a protease. And lastly, a little important fact is that along the columnar epithelial cells, we have microvilli. This is another mechanism for increasing that surface area. The microvilli are little knobbies sticking out all over the surface of the columnar epithelium. And we have actually got the ability to produce enzymes in those little microvilli called brush border enzymes. And that's where we're going to finish our discussion today. So we're going to finish this up on Wednesday, finish up our whole digestion system on Wednesday, a presentation, looking forward to it, and I'll see you then.